So my name is Jim Cowen, and I'm going to go first, Chairman Miller, and so thank you, Senators, for attending. I'm a physician and internist. I practiced medicine in the United States since 1981. I know I have an English accent, so that might be of interest to you. I worked in hospital medicine, academic medicine, private practice, and I worked for a large health insurer in the U.S. I've also done consulting work for that insurer with the National Health Service in the U.K., and I've worked as a consultant with other insurers in the U.S., Europe, Middle East, and Asia. And what I would like to do this evening, and I thank you for the opportunity to combine our testimony, because my message really applies to all three bills and leads to a specific conclusion. And what I would like to do is talk about some of the basic arithmetic issues with health insurance and explain why health insurance is different from other kinds of insurance, and why that leads to a conclusion that a Medicare for all type solution is the only one that's actually going to solve the problem of the failure of the individual health insurance market in the United States. So I have two questions I want to ask rhetorically and then answer. The first one is, why do you get your health insurance through your employer or through the government, rather than go down the street like you do for home, auto, and life insurance and buy it from an agent in your neighborhood? So what this tells us is that health insurance is fundamentally different from home or auto insurance or even life insurance. And the reason for that is that the replacement cost of your home is a known quantity. When the insurer has to pay out because your home burns down, then the insurer actually knows ahead of time what they're going to have to pay out. Same is true if your car is totaled, and the same is true for a life insurance policy, because it states on the policy what they're going to pay out. So these things can be assured. If you know that a home burns down, 1 out of 1,000 homes burn down every year, and your home costs $100,000, then your premium is $100. It's very simple. But if I ask you the question, how much is your health care going to cost next year, you can't answer that question. And that's why health insurance is different from other kinds of insurance, because technically the requirement to insure something is you know what it's going to cost you if it's destroyed. And you don't know that about your health. So the health of an individual person is actually not insurable. Even though we have a health insurance industry which attempts to do that for individuals, they're doomed to failure. And this is why the individual health insurance market is the health insurance market that fails in the United States. The health of an individual is not insured. But what I can tell you is that if I wanted to issue appendicitis insurance, I know that 1 out of 400 people every year will get appendicitis. Technically 1 out of 400 people that still have an appendix, but you get the point. And 1 out of 4,000 people, with 4,000 people, then 10 of them will get appendicitis. And out of 400,000 people, then 1,000 of them will get appendicitis. So I can be very confident with a group of people how much I'm going to have to pay out for appendicitis insurance. And the same thing goes for cancer, heart disease, and everything else. So if I have a group of people, I can insure their health. I can't insure the health of an individual, and this is just arithmetic. This is actuarial science. I'm not speaking from the politics of the left or the politics of the right. This is just like hard facts that anyone who's going to address this problem needs to deal with. So we can insure the health of groups of people, and this is why everyone who needs to have health insurance, which is actually everyone who has a body, needs to be in a group. They need to have access to a group that they can join so that they can be insured at a reasonable cost. Medicare for All offers the opportunity to put people into a group, in this case a single group, which guarantees them access to health insurance. So that's my first point, that groups are good, groups provide access to health insurance. Medicare for All is a way to do that. There are other ways to do it, including some fairly radical tweaks to Obamacare, and other ways that one might achieve this state of everyone being part of a group, but it has to be part of the solution. So I would urge support for the resolution to our federal regulators that they support Medicare for All or a similar solution equivalent in the sense that it guarantees access to a group. The second question I would like to ask and consider is, why does your employer, if you have health insurance through your employer, why does your employer have an open enrollment period after which you can't get into the plan until the next year? Whereas you can buy your home or insure your car at any time of the year. And once again, the answer is that health insurance is fundamentally different from insuring property like a car or a home. So the reason that there is an open enrollment period is that it prevents something called adverse selection, an insurance term that I'll explain in a moment. But adverse selection is what leads to the failure of the individual health insurance market, and it is why we have now, with the changes that Trump has made to Obamacare, that we have adverse selection in a greater degree, and that's why we have increasing numbers of uninsured people again in the United States this year. So what is adverse selection? Well, patients adversely select against insurers, one, by not buying health insurance at all, which means that the insurance pool is smaller, so there's less premium revenue in it, and the people in it are sicker, so they have to pay out more. And that goes on for a while, and the insurer gets out of the market because they're losing business. Patients, and insurers adversely select against patients by excluding people with pre-existing conditions. So the insurance pool excludes all the sick people, which is good for the insurer, or they charge very high premiums to people with pre-existing conditions, so people can't afford it, so they're not in the insurance pool, or they offer policies that are cheap but don't really cover anything. And what this means is that sick people are not covered or not covered effectively. And these two things, the patient's not buying in the first place and the insurers excluding sick people, contribute to the fact that the bankruptcy in the United States is primarily due to, the most common cause of it is medical costs. And most of the people who go bankrupt have health insurance. But you've got to ask the question, well, what kind of health insurance do they have? And the answer is obviously not very good. So any solution to this requires that you eliminate this opportunity for adverse selection. And the way that you do that is twofold. You do it through mandates. And the first mandate is patients, that you require every patient to participate in a health insurance program. And by doing that, you prevent people who don't think they're going to get sick from opting out. And you make sure that the premium revenue in the pool is maximized. And you also include all the sick people in the pool by doing that. And the second thing you have to do is a mandate on the insurance companies that requires them to offer a comprehensive package of benefits that covers all conditions that can be treated and covers all treatments that are scientifically effective. And by doing those two things, a mandate on patients to participate and a mandate on insurers to offer a satisfactory package of benefits, you eliminate the possibility for adverse selection, and your insurance market, even individuals, will then be successful and will continue. And we have examples of this. One example is the employer-sponsored insurance, which requires people to participate and prevents them from, it doesn't require people to participate, but it prevents them from joining later when they get sick. And we have examples with Medicare, and Obamacare that lay out a clearly defined package of basic comprehensive benefits so that people with pre-existing conditions can participate and get treatment that they need. So if the goal is to provide access to health insurance for every American, then we have to do two things. One is we have to offer a comprehensive package of benefits by the insurer, and the other is we have to mandate people to participate in the insurance program. And if we do those two things, then we'll have a successful health insurance market for individuals. Medicare for all is one way to do that, and as I said before, there's other ways to do it that would achieve the same goal. So with regard to the study commission, then if our goal is universal affordable health insurance for every American, which I'm assuming it is in this gathering, then we have two problems we have to deal with. One is coverage. How do we give people access to health insurance and thus to health care? And then the second is the cost of health care. because the cost of insuring a family today is about $26,000 a year, and the median income in the US is $56,000 a year. And you put those two things together, and you can see right away that 50% of people in the US can't afford health insurance at all, and even people with a low six-figure income would have trouble paying $26,000 a year before tax to buy their own health insurance. So it's fundamentally unaffordable because the cost is too high. To solve this coverage problems, we need a mandate on patients to participate and a mandate on insurers to provide a basic comprehensive package of benefits. That addresses coverage, but it doesn't address cost. So let me tell you a story from my experience about cost to illustrate why we need a single payer type solution to deal with costs. When I worked for a health insurer in the United States, one of the things I did was to help to build what at that time were called or are called accountable care organizations, which was not a product of Obamacare, but it was something that was introduced at the same time. And the idea was that payers, like a health insurer, and providers of healthcare, like a large healthcare system, would get together and figure out how to lower the total cost of care to a population of patients that they were insuring and looking after. So that was the goal. So I go to a meeting. On one side of the table, I'm sitting with the health insurer people. I'm the data guy. I'm the doctor that has all the data that's going to show where these opportunities are. And on the other side of the table, there's the hospital healthcare system people led by their chief financial officer. And so the meeting begins, and people turn to me and say, hey, Jim, what opportunities do we have here? And I say, well, we'd had 1,000 MRI scans done last year on these patients here. And each one we paid $1,200 for, because that's the contracted rate with the healthcare system. But down the street, there's a freestanding MRI center that was a competitor to the healthcare system, where the contracted rate for an MRI scan was $400. So there's an $800 saving opportunity on the table, and there's 1,000 of these things being done each year. So there's $800,000 on the table. And so I say we could do that. Are you willing, health system, to send your patients down the street to the freestanding MRI center? And the CFO of the health system leans forward in a somewhat menacing way across the table and looks at me and says, no. And my compatriots on the Aetna side, on the health insurer side of the table then say, okay, what have you got next for us, Jim? So this opportunity is lost. And you have to ask yourselves at this point the question, well, who's wearing the black hat in the room? Who's the bad guy in the room? Now, the CFO of the health system has a responsibility to meet his payroll so that he can keep his health system in business and fulfill his obligation to the state that's licensed this healthcare system to provide healthcare to people in that community. So he's doing his job. He's maximizing his revenue for that institution. From society's point of view, this is not a good situation, but you can't fault him for what he's done. And on the health insurance side, when I worked in health insurance, on the health company intranet, the internal website, on the first page in the top right-hand corner was the stock price of the company. And the goal of the company was very clear, was to maximize shareholder value, as it is with any public corporation. And that's driven, shareholder value is driven by current revenues and the expectation of future revenues. So if you have a situation where you've got a $1,200 MRI and you have to choose a premium, set a premium to cover the cost of that, you're going to get revenues as an insurer that are high enough to cover that $1,200. If you get into a situation where the MRI cost is only $400, yes, you can drop your premium, which might make you a little more competitive, but health insurance is a mature business, so that doesn't give you much advantage. But if you drop your premium revenue, then your corporate revenue goes down, and what happens to your stock price? It's going to go down. So the health insurer is actually not acting as an agent for the patient or the employer who's buying insurance in that community. The health insurer is acting as an agent to maximize its revenue, and the people on the insurance side of the table are actually doing their job in the framework that they've been set up in. And this sort of thing goes on all the time. There are other reasons why healthcare costs are high, but this illustrates that there is a structural problem with the concept of competing private health insurance in the country, which gives no insurer the opportunity to leverage and negotiate prices down and penalizes them if they do, which prevents effective cost control in healthcare. And this is why we have the healthcare costs that we have. So, if we're going to make health insurance affordable, most people can't afford it without subsidies, the cost is not going to be controlled unless we have a negotiating entity which has enough market share in each community, which no insurer does at the moment because they're fragmented, and that market share is then allows you to negotiate prices down. So this again is a reason why a single payer solution or equivalent with defined benefits and mandatory participation is the only solution that's going to be effective in solving the crisis in individual health insurance market and the cost of healthcare in the United States. So I believe that a study commission that could examine these issues from the point of view of not starting with how do we tweak the existing system, because the existing system is structurally set up in a way that guarantees its failure in the individual market. But a commission that's set up to start from the basic principles that I've laid out here, and then examines how a final solution could be set forth that would be desirable and develops a pathway to get there, because I realize that politically this is not easy, but that would be a good path forward for Rhode Island. So I would support the establishment of a study commission. Thank you.